I was standing right there, post up day 3. His name was Mr. R. Doing fine. And then all of a sudden, his ventilator alarm went off. High peak pressure. Again and again. The nurse on duty silenced it. She suctioned. She adjusted the patient, but the alarm kept screaming. Like, like screaming. So she did what she thought was right in the moment of panic. She increased the pressure limit on the ventilator. She was trying to ease the struggle. Within 5 minutes, its oxygen saturation SpO2 dropped to 82%. Remember, the normal we should have is 95 to 100. And then for a COPD patient, 88 to 92%. Its blood pressure tanked. That means it went low. And in that terrifying silent room, I realized the intervention she did to help the patient had just made everything worse. The ICU attendant ran in, looked at the ventilator settings, and asked the entire room, the forward, the change, how I see critical care. Who changed these settings? In that moment, I realized I had no idea what had happened. I didn't understand the fundamental difference between fixing the alarm and fixing the patient. The day that day changed how I think about mechanical ventilation. Because here's the thing, ventilators don't just breathe for your patient, they can seriously hurt your patient if you don't understand the physics and chemistry revolving around the ventilator. And in nursing school, they teach you how to suction a tube, but they don't teach you how you can think like a ICU nurse when the alarm goes off at 2 a.m. and you're the only one watching the patient. So today I'm going to teach you everything I wish I knew when before I witnessed that alarm. We're going to break down the mechanical ventilation, not the textbook version, the real version, the version that actually keeps the patient alive. Now, this is going to be like 30 to 50 minutes. So grab your coffee, get your notes, and let's go. Because the next time this type of alarm goes off, you're going to know exactly what to do. So let's start. So the question, why does this matter? Well, mechanical ventilation, I'm going to call it MV, mechanical ventilation. Why does mechanical ventilation scare nursing students? Well, because it's complex. There are a lot of modes, settings, alarms, pressure, volumes, and every single one of them can either save a life or end one. The stakes. Wrong settings, barometer, that's lung damage, long alarm response, hypoxemia, that's when the tissue has less tissue, when the tissue has less oxygen, wrong tube position, Lord have mercy, that is death. Okay, now this is not like giving medication where you have a few minutes to fix a mistake. With ventilators, you have few precious seconds. But here's the good news. Once you understand the principles, everything else clicks into place. Um, Today we're going to be covering how ventilators actually work, the physics nobody explains, the modes you see on the floor, the alarms and what they really mean, the mistakes that hurt patients, and how to think like an ICU nurse. I'm going to be using stories, that's real situations that I have witnessed and experienced, because that is how this stuff actually makes sense. Sound good? Let's do this. Okay, how ventilators work. Positive pressure ventilation. PPV. Positive pressure ventilation. We use a lot of acronyms in nursing, so it takes a while to get used to, but it happens. So first thing you need to know, ventilators work opposite of normal breathing. Uh, lungs. Lungs, it's like this. Normal breathing. Your diaphragm contracts, creates negative pressure in your chest. So your diaphragm contracts, negative pressure, air gets sucked into your lungs. That's how you breathe normally. Like, see, mechanical ventilation, machine push air into your lungs, like create positive pressure opposite, and then the air gets forced in. What? Why does this matter? Because positive pressure affects more than just the lungs. It affects your cardiac output, CO. It can, and if it's affecting your cardiac output, it's going to reduce your blood pressure, your venous return. Basically, that means it's going to reduce the blood flow that goes back to your heart. And then kidney function. Remember, the kidney is very sensitive to anything that affects the heart or affects blood flow. It's like it's one of the ones that would show. So for the kidney function, the pressure on the vessels. So basically, positive pressure caused by mechanical ventilator affects more than just the lungs, because it affects your cardiac output, which then drops blood pressure, venous return, which then reduces the blood flow that comes back to your heart, and then kidney function because of the pressure on vesicles. Now, this is why patients on high PEEP, PEEP means positive, PEEP means positive and expiratory pressure PEEP. It's used to it's used with the mechanical ventilation. It's like it's looking quickly or secretly. It's like a high pitched sound. It's a positive pressure that is applied at the end of exhalation by your mechanical ventilation to help keep the small air sac alveoli, that's the one that looks like grapefruit, small grapes, in the lung from collapsing. Make sense? Okay, let's continue. So that's why patients on high positive and expiratory pressure PEEP sometimes get hypotensive. Hypotensive is low blood pressure. This blood pressure is literally squeezing their blood vessels. They are really contrasting. The blood vessels is squeezing. Now PEEP, PEEP. I don't know if you can say it. I don't know why it's the right. Anyway, PEEP, like I explained earlier, is the pressure that stays in the lungs after you exhale. So It's the pressure. It still stays in the lung after you've. This is inhale, exhale. Think of it like keeping a balloon slightly inflated instead of letting it fully deflate. So, why do we use it? Because it keeps alveoli open. It prevents the collapse. Remember, alveoli is the grip, grip looking, small grip looking. We use PEEP to improve oxygenation, and we use PEEP to reduce WOP, to reduce work of breathing. If there is no positive end expiratory pressure, PEEP, alveoli collapse. And if alveoli collapse, patients cannot oxygenate. If there is PEEP, alveoli stay open. Better gas exchange. Gas exchange is inhale, exhale. But here's the catch. You can't have too much of everything. You have to have it in moderation. Too much PEEP can cause barotrauma. That is when the lung is injured from the too much pressure. Hypotension. That is where your blood pressure is low. It drops. Pneumothorax. That is when the lungs give up and collapse on you. So when you see PEEP at 10 or 15 or 20, 10 to 20, that is significant. The patient is critically ill and needs close monitoring. Like they're very sick. They need like really, really close monitoring. Make sense? So far, so good. Now, let's talk about the settings you actually see. Ventilator settings explained. Let's see. All right. So when you walk up to a ventilator, you're going to see a bunch of numbers. Maybe I could add in a picture of a ventilator. Yeah, I'll try. I'll see when I'm editing. You're going to see a bunch of numbers. Let me break down the main ones. FiO2. FiO2 means fraction of inspired oxygen. This is the percentage of oxygen the patient is getting. Like this is percentage of oxygen they're getting. For a normal healthy human being like me and you, room air is 21%. That's like for a normal person. Then ventilator can deliver 21% to 100%. That's the ventilator. But we as human beings, we're all on 21%. Now, the clinical peer. If your patient needs FiO2 above 60% for more than 24 to 48 hours, something is wrong. The oxygen toxicity, that's like oxygen toxicity territory. Remember, oxygen is a medication. I know sometimes because of the way we use it, we don't think it as a it is a medication. Oxygen is a medication. So you need to figure out why they need that much oxygen. Because remember, 21% is for a normal healthy person. So if your patient is on FiO2 of 60 to, to 100 for more than 24 to 48 hours, ding, 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 something is wrong. So, setting 2. FiO2 was setting 1. Setting 2. Your tidal volume, your TV or VT, different acronyms. This is the amount of air delivered with each breath. So our normal tidal volume is 6 to 8 ml per kilogram of body weight. So if a patient weighs let's say 70, that's my favorite kilogram. The patient weighs 70 kilograms and you're expected to have 6 to 8 ml. But our professor told us if she gave us this scenario, we should always stick to 6. Okay, so I'm going to give you the maths. So you're going to basically do 6 times 70, which is so if my patient is 70 kilogram and I'm giving them 6 ml tidal volume. Remember, tidal volume is the amount of air delivered after each breath. They would have 420 ml. And then if I was going with the 8 ml, that's within the range. So it would be 420 to 560. That'll be the range for this 70 kilogram patient. So it's depending on the patient's weight. So tidal volume will be 40 to be 420 to 560 ml for this 7 kilogram patient. Now, here's why this matters. Too high of a tidal volume can cause volutrauma over distension of the alveoli. That means the lung literally gets so stretched out, it's damaged, like it's over inflated. You know, when you, okay, I don't know if this is a good example. When you blow a balloon so much and you keep blowing it and it gets bigger and bigger and bigger, what does it do? It's bursts. I'm not saying the lungs is gonna burst. Maybe it's gonna. I don't know. I don't. I'm not gonna go down that road, but it's basically going to be damaged. So that is why we don't do 10 to 12 ml per kg anymore, because back then they do 12 to 10 to 12 ml per kg. But we learned that low tidal volume ventilation protects the lung. That is why our professor wants us to use 6. Always use 6. Make sense? Okay. Setting 3. That was just 2 settings so far. Setting 3, respiratory rate, RR. How many breaths per minute is the ventilator delivering? Usually, it's always set within normal of a human, of a healthy person breath, which is 12 to 20. We have 12, well, adults, let me specify. Adults have 12 to 20 breaths per minute. It's different for kids. Kids they tend to have high on the higher side, but for adults, 12 to 20 is the normal breath per minute. But here's the thing, the total rate might be higher than the set rate. Why? Because the patient might be triggering extra breathing on their own. So if you see set rate 14, so maybe they set the patient's rate RR to 14, the patient's total rate is 22. The patient is breathing extra. That means the patient is breathing over the ventilator. This is not necessarily good because it means they are working hard. Their body is working hard because they're on the ventilator, so the ventilator should help them do this. But if it's more than the set rate, they are breathing, they're working hard, they're in distress, they're in pain, they are anxious. So you need to access why. Don't just chat to the number, it's not normal. You need to find the underlying problem. Now, settings 4, your PEEP. We talked about this already. Remember, the PEEP is the positive and expiratory pressure. It's usually 5 to 20 cm H2O. So the higher the PEEP, the sicker the patient. So if you come, you check the ventilator, you see a patient on 10 centimeter H2O, that patient is really, really sick. Now, pressure support. Like if they're in PSV mode, uh, that's pressure support. Basically, it helps patients take their own breaths with less work. So it's like a boost. Here is a boost to help you, but you're still doing it yourself. Like when I'm working out, my like the other day I was doing a deadlift of 50 pounds. I was able to do 10 successfully on my own, but then I was getting tired and I had to get to 12. But then at 10, my body was like, oh, no more. But then my personal trainer helped me to complete it to 12. Basically, it's a boost. You can do it, but it's a boost to help you not to work so hard. Now, yeah, is what nursing school don't teach you. The settings are not random. You don't just see a patient and you see the random settings. They are based on patient diagnosis. So if the patient have ADS, I think I talked about this already. ADS, acute respiratory distress syndrome, that's the meaning of ADS, ARDS, or versus a patient that has COPD. You're going to do different strategies for this patient. It also depends on their blood gases, arterial blood gas, ABGs. Is the CO2 high? Is the oxygen low? Their lung compliance? Are their lungs stiff or is their lung stretchy? Do they have enough surfactant? Surfactant. Surfactants. Yeah. I don't think I'm pronouncing it well, but I hope you get it. So this is why you never change ventilators settings without the without an order, without the outie, because changing one thing affects everything else. You might think you're saving a patient, you're helping them, but it just changes everything else. Now remember Mr. R we talked about earlier? I the pressure does not increase the pressure limit without understanding that high pressure was the ventilator way of saying something is wrong. So they silenced the symptom instead of finding the problem. They thought they were helping, but they were not. So don't be that nice. Understand the settings so you understand the alarms. Now let me have a quick break. The next one we're going to be talking about is modes of ventilation. Okay, modes. This is where people get confused, but I'm going to try to make it as simple as possible. Now, modes of ventilation: assist control A/C, SIMV, SIMV, pressure support PSV, CPAP. Now, think of mode like levels of support. Some modes do all the work, and some modes let the patient do the work. Now, I'm going to break down each mode. So now we have the assist control mode. This is when the ventilator delivers set number of breaths. Patients can trigger extra breaths. Every breath gets full support, full tidal volume. Who needs this? Very sick patients, patients who are post op and they're having complications, so post op patients, anyone who can't do the work of breathing. Risk for AC is Risk for AC if is hyperventilation. Patient is anxious and breathing fast. They are getting full breath every time. It could lead to respiratory alkalosis. Clinical pair. If your patient on AC access control is breathing 30 times per minute, 30 breaths per minute, something is wrong. You should assess for pain, anxiety, and worsening condition. Mode 2, SIMV, also known as synchronized intermittent mandatory ventilation. Ventilator delivers set breaths. Patient can get their own breath in between. Their own breath get less support. Um, who needs this? Weaning patient. So if you're weaning patient, because we do this sedation, oh no, that's for sedation. Anyway, we do this thing where we take patients off ventilators to see how they're doing, like on room air, and if they do okay, they take it off, and if they don't, they put it back on. Either they increase or reduce depending on the situation of how patient outcome is. Anyway, winning patient, those are the winning patients. You also uh another person that would need the synchronized intermittent mandatory ventilation SIMV would be patients who can do some work but not all of it. So so this mode lets patients practice breathing while still having backup support. So mode 3, this is the pressure support, PSV. There is no set rate. Patient triggers every breath, then ventilator give them boosts of pressure to help. Now, this is like training wheels on bike. If you know, if you have two wheels on the bike and training wheels, they put that extra two wheels. That's like it. The patient is doing the work, but is getting help. Who needs this? So you give this to your winning patient with good respiratory drive, but weak muscles. If a patient on PSV stops breathing, the ventilator won't breathe for them. So if it's like they breathe, boost. If they stop breathing, the ventilator won't breathe for them. So this one requires that the patient has a reliable respiratory drive. Now, the fourth mode. The fourth mode is the CPAP, continuous positive airway pressure. The patients breathe on their own. Constant pressure keeps the airway open. No ventilator breathes for them. This is the least support. It's the least invasive. Patient is doing all the work. Who needs this? Patients with sleep apnea, patient with sleep apnea, patients being weaned who just need little pressure to keep airway open. Now, it is important to note that CPAP is different from PEEP. Continuous positive airway pressure is different from positive and expiratory pressure. God, this my mouth is tired. Let's continue. Uh, it is different, but they're similar. CPAP is different from PEEP, even though they sound similar. Now, PEEP is pressure at the end of the exhale. Pressure, end of the exhale. CPAP is the pressure throughout the whole breath, like it's the whole pressure throughout the whole thing. Now, so when you're on the floor and you see patient on assist control, know that they are very sick. Ventilator is doing all of the work for them, or most of the work for them. If you see a patient on SIMV, they're getting better, but they're sharing the work. It's like this is where those 50-50 they do in relationship. Yeah, this is the 50-50. The same V is the 50-50. The AC is the full on support. The PSV is like, okay, we're almost ready to get them off oxygen or wean them off. Then your CPAP is ready to come up the vent. So that means if they're on CPAP, that means in the next few hours they're gonna or days or day, not in the next 24 to 48 hours they're gonna come off the vent. Make sense? Good. Now let's talk about the alarms because this is where things go wrong. I have some good pictures that I could relate to that I can show you on my textbook. But we're going to continue. It's the sole introduction to critical care nursing. This is a ninth edition. This is what we're using in class right now. So this chapter I'm going over is chapter 10, but we'll go more later on it. So this is the most important segment of it. The um the alarms and troubleshooting, because when the alarms goes off at 2 a.m. you're alone in the room, you need to know what to do. So let me tell you what I learned the not so easy way. um Never silence an alarm without figuring out why it's going off in the first place. Don't even touch the alarm, especially if you're a nursing student on your on your rotation and it's making noise. Get your nurse. Get your nurse or someone more experienced that knows it. Don't yes, you learned it in school, you learned it in class, but please don't touch the alarm if you don't know why it's going off in the first place. Now, golden rule. Golden rule, as gold as my glasses. Alarms are symptoms, not problem. So when the I think for each setting modes on the ventilator, it has its own type of alarm. I think there's some alarm you hear, you're like, okay, yeah. Like especially on the IV, like the fluid, when the thing is almost done, it start making that noise. They're like, okay, you just come and like reset it or something. But you see the alarm from the ventilator, you cannot just press a button to silence it or anything. It's a symptom. It's telling you, it's trying to tell you something. It's trying to communicate with you. So when Mr. R high pressure alarm kept going off, it was treated as a the alarm was treated instead of like finding the cause of why the alarm was sounding in the first place. The cause, he had a mucus plug blocking his tube. His body was trying to push air past the blockage, and the ventilator was saying, I'm using too much pressure to deliver this breath. Like, the body actively trying to push past the plug. And the ventilator is like, oh, I'm using too much pressure to deliver this breath. You should have suctioned. It should have been suctioned. Instead, pressure limit was changed and it was made worse. Don't go above or below or anything with that is not the order or is not the RT that did it. Don't do that. Okay? Let's go through the common alarms. So, alarm one, high peak pressure. It means ventilator is using more pressure than expected to deliver the breath. Causes why the alarm will be given this type of why the ventilator will be given this type of high peak pressure alarm. It's because patient is coughing, patient is biting the tube is kinked, that means tied or something, mucus plugged, secretions is blocking airway, patient is anxious and fighting ventilator, pneumothorax, collapsed lung, bronchospasm, airways are tight. Bronchospasm might be seen in asthmatic patients on ventilator. Now, what do you do? Look at the patient first. Yes, you look at the machine, obviously, but look at the patient numero one first. Are they awake? Are they anxious? Are they coughing? Check tubing. Is tubing kinked? Is it twisted? Is there water in tube? Listen to lung sounds. Oxygenates. Are they equal chest expansion? Is it clear breath sounds? Do you hear wheezing? Is it silent on one side and not silent on one side? Is it diminished? Like when you come to the hospital, you always have to do your assessment. So is it different from your assessment in the morning? Suction if needed. If it's still alarming and you've done all of this assessment, please call rapid response. No. Please call OUTI, respiratory therapist, or you call provider, depending on whichever one is closer and more easy to access. Red flag. If breath sounds are absent on one side and high pressure alarm, think pneumothorax, collapsed lungs. This is a medical emergency. Pneumothorax, collapsed lungs is it's a medical emergency, and you need to call for help immediately. Rapid response team, code blue, anything necessary to get help by your side instantly. Um, your second alarm, and I'm having chest pain. I don't know. I'm having something. Alarm two, low pressure. What does this mean? Ventilator is not building up enough pressure. What can cause it? Disconnected tubing. So the tubing to the patient to the thing is disconnected, which is the most common one. There's a leak in circuits. There's a leak in ETT cuff. The ETT is dislodged. Remember, ETT is endotracheal tube. So the one that goes from your yeah mouth. See from here. I'm trying to remember. Yeah, the tube came out partially. Now, what do you do? Well, you check all connection. Tube to ventilator, ventilator to humidifier, every single connection point. Because this thing always have like a lot of connection, like three to connecting. Check ETT cuff pressure. It's normally checked every 4 hours. So it should be 20 to 30 cm H2O. If air if low, air is leaking out. So if it's lower than ordered, maybe it was ordered for 25 centimeter and you're seeing 15 centimeters probably leaking out. Look at tube position, check the marking at the tip. So they always put this thing, so they'll be like ETT tube 16 French at 65 centimeter at lip. That means like when you do the ET2 tube, you check it from patient mouth to where you place it, like basically here in the tongue area. So if the documentation says, oh, 65 at lip 65 centimeter, and then you check it and it's at 60 centimeter, that means it has moved. So you want to check for that. Now, if you can't find the problem in 15 to 30 seconds, manually ventilate with bag mask. That's the ambu bag, AMBU bag, ambu bag, and call for help. Ambu bag is that one you use during CPR when you do 30 and you give two air. You put it on the patient and then you squeeze. And before you do that, call for help so that someone can come and while you're manually ventilating patients. Never let your patient go without ventilation while you're troubleshooting. Okay? Alarm 3, low oxygen saturation. It means patient SpO2 is dropping. Now remember, SpO2, your normal is 95 to 100%. So what can cause your SpO2 to be dropping? Secretions. That means they have secretions and they need to be suctioned. Worsening lung condition, mucus plug, when mucus plug is blocking the airway, pneumothorax, collapsed lung, pulmonary embolism, that is when blood clot is in the lung. Ventilator disconnection, that is when the ventilator is disconnected from patient. Now, what do you do in this situation? You want to increase the FiO2 to 100% temporarily. Emphasis on the word temporarily. Assess your patient, lung sounds, skin color. You're assessing for skin color because if you see blue, that means they're cyanotic. They're not getting enough blood. That's not good. Work of breathing. Are they breathing hard and fast? You can tell when someone is breathing hard and fast. Imagine just running marathon. How does that person breathe? Yeah, work of breathing. Suction. You want to suction them, and then you also want to call for help if you've done all of this and they are not improving. Now, if SpO2 drops below 88%, despite all the amazing things you've done to help this patient, you are in trouble. No bad word, you're in trouble. The patient is heading towards respiratory failure, acute respiratory failure, or cardiac arrest. So you back them. When I say back them, that means the amber bag, and you call for rapid response and you prepare for the worst. Prepare to have everything done on your patient. Your patient the DNI, all of that stuff. And yeah, prepare for worst, basically. Alarm 4, the apnea alarm. It's when the patient has not taken breath. So they're breathing, they've not taken a breath. Patients, the causes, potential causes is patient is too sedated, patient respiratory drive is suppressed. Respiratory drive being suppressed will be mostly found in COPD patients. That's why it's so hard to ventilate one, because once you ventilate them and they're receiving all this oxygen, it's hard to bring them off, because sometimes when you do that, they die. There's no respiratory drive. Ventilator mode does not have backup rates like PSV. Now, what do you do for these patients? You immediately assess. Remember, you always want to assess. Remember your ADPI. So starting fundamentals. Never forget that ADPI. Assess D. No, not documents. Oh shoot, what's D? I forgot. I just literally said it a moment ago. P is plan. The D will come back to me. I is implement. E is A is assess. D is diagnose. P is plan. I is implement. E is evaluate. Left 5 minutes. Okay, at pi. So you always want to assess first. Assess. Are they breathing? Are they conscious? Stimulate patient. Oh, Mr. Joe, Mr. Smith, Mrs. Smith. Call their name, shake their shoulder, tap them. They are not waking. If not breathing, amber bag, manually ventilate, check sedation drip. Are they getting too much? Are they on propofol? Are they on levofed? Are they on, yeah, any of those drips? Check. Call provider. This is why you don't put heavily sedated patients on PSV or CPAP. They need to be on a mode with backup rate. That's we're thinking SMV, we're thinking SIMV, and we're also thinking AC for this patient on heavily sedated patient. You don't want to put them in PSV or CPAP. Remember, this is the one that just boosts them. If they don't breathe, it doesn't breathe for them. You want to put them on something that helps them. All right, I know that was a lot, but here's the summary. Even I am feeling I talked a lot. I don't know, is this how professors feel? Oh Lord. When alarm goes off, look at patient first, not monitor. Assess quickly. 30 seconds max. You should be able to assess them within 30 seconds. If you can't fix it immediately, back them manually, amber bag, and call for help. Doctors are not the fastest way to go. This is where you want to call your rapid response team. Get them to come help you. Your job is not to fix the ventilator. We do not know how to do that. Your job is to the patient. Keep the patient alive while you wait for help to arrive. Remember, I'm going to say it again. Your job is not to fix the ventilator. Your job is to keep the patient alive while you wait for help. Got it? Good. Now, we're not done. We still have more. Let's talk about complications. Mechanical ventilation saves life, but it also causes harm. Let me show you the complications you need to watch for. Or let me tell you the complications you need to watch for. Complication 1, ventilator associated pneumonia, VAP. Remember WAP, but VAP. Ventilator associated pneumonia. This is an infection that develops in intubated patient. Why? Because the tube bypasses all normal protective mechanism. No cough reflex, no gag reflex. Bacteria can slide right down the tube into the lungs. Free ticket. The water slide, you just film. That's how the bacteria goes. Film. That is why for this patient, they are classified immunocompromised. You want to be as aseptic as possible because you want to prevent them from having VAP, ventilated associated pneumonia. So, how do you prevent VAP? This is where we have VAP bundle. You want to keep patient head of bed 30 to 45 degree to prevent aspiration. Aspiration is something from inside coming. You want to prevent that. Oral health with chlorhexidine. Chlorhexidine is that chlorhexidine. You should know chlorhexidine if you're in the healthcare field. Daily sedation vacation. Assess if they can be extubated. Every day, when you come morning shift, you do sedation vacation. Suction above the cuff. Get secretions before they go to the lung. So if you see a secretion, suction. DVT prophylaxis. That is when you put in your SCD, you put in your wedge. Yeah, those good stuff. Compression sucks. Stress also prophylaxis. If a ventilator, they're not able to eat, so they'll probably be on tube feeding, TPN, PPN. You want to give them PPIs, that's your protonics, yeah, to help with the GI. Now, every single hospital follows this bundle. It might be assessed, or it might be tweaked to the standards, but this is like the common bundle. You see it on your unit, follow it religiously. Now, complication two, barotrauma. This is when the lung is injured from too much pressure. High pressure can cause pneumothorax, lung collapse, tension pneumothorax, which is life-threatening emergency. Subcutaneous emphysema, which is air under the skin, like you could literally see air under the skin. This is why when you're giving IV, we are so strict about no air bubbles. Get it? Signs of pneumothorax: sudden drop in O2 sat, in oxygen saturation. Maybe their baseline, their normal is 98, 96, and all of a sudden you're saying 80. Ding, 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 ding. That alarm should be going off. Brain. Eye peak pressure alarm. Absent breath sounds on one side. Tracheal deviation. That is a late sign. Tracheal is deviated to the left, to the right. Late sign. Patient looks terrible. Yeah. If you see this, call for help immediately. Tension pneumothorax is decompressed with a needle. It's first done with a needle to let the air out, then chest tube. Minutes matters. Complication 3, volume trauma. This is lung injury from too much volume. This is why we use low tidal volume of 6 to 8 ml per kg, preferably 6 ml per kg. Overstretching alveoli causes damage similar to ARDS, acute respiratory distress syndrome. Complication 4, oxygen toxicity, lung injury from high FiO2 for too long, FiO2 above 60 for more than 24 hours. Not good. This is why we use PEEP to improve oxygenation instead of just cranking up the oxygen. The PEEP, positive and exploratory pressure. It's better to use moderate FiO2 plus PEEP than to use 100% oxygen, because remember, oxygen is a medication. Now, the last complication, psychological trauma, the brain, mental. Being intubated is terrifying. Patient can't talk, they can't communicate, they can't eat, they can't move freely, they are dependent on the machine. This is why many patients develop PTSD from staying in ICU. So, yes, you monitor the ventilator settings, but you also talk to your patient, talk them through everything you're doing, explain what is happening, hold their hand. A human being needs 7 non-sexual touches a day. Non-sexual touches, holding hands, patting them. We need 7 every day, like normal healthy human being. So what's more, someone in the hospital. I know we do a lot of clinical touches, but let's always try to incorporate non-sexual touches. Hand, hold their hands while you're explaining. Give them a communication board. Like I think there's the one where you can write if they can write, or you give them the one where they type what they want to say. Because you're not just managing a ventilator, you're caring for a human. So, weaning and extubation. This is good news. Okay, let's talk about the best parts of mechanical ventilation. Getting people off it. That's the best part. Weaning is the process of gradually reducing ventilator support so that the patient can breathe on their own. How do you know a patient is ready to win? Remember from the sedation vacation, but there is winning criteria. Underlying problem is resolved. Maybe they came in for pneumonia or sepsis and that it's treated or the sepsis is improving. Like you know from labs and how patients is doing overall. Hemodynamically stable. They have good blood pressure. They're no longer on pressors. Adequate oxygenation. FiO2 is less than 50% and their PEEP is less than 8. So if the PEEP is 6, the FiO2 is 30%. That's good prognosis. Mental readiness. They can listen to you, they can follow commands. Strong cough. Protect airway. They are able to protect their own airway. Once these criteria are met, we do a spontaneous breathing trial, SBT, spontaneous breathing trial. This is basically a test. Can you breathe on your own with minimal support? Remember, I told you this is the winning process, but we put the patient on PSV with minimal pressure support or TPs. Basically, it's just oxygen, no ventilator. And then we watch them closely for 30 minutes to 2 hours. Now, signs patient is failing on the spontaneous breathing trial. Respiratory rate is above 35. Oxygen saturation is less than 90. Increased work of breathing. They're using the accessory muscle that increased work of breathing. They're sweating, diaphoresis, they're um, tachycardia. Basically, their heart rate is higher than normal, which is 60 to 100. Your bradycardia, if it's lower than 60. Anxious, agitated. If they fail, we put them back on full support and try again tomorrow. If they pass, we extubate them because extubation is taking the tube out. So, before you extubate, you want to suction the endotracheal tube, get the secretions out, suction above cuff. You don't want secretions to fall into the lungs when you deflate the cuff. So suction above cuff. You have patient take deep breath, deflate cuff, and deflate cuff by using the syringe and drawing, and then pull. Then immediately you give them oxygen valve, face masks, assess for stridor. You're not doing it alone, you have someone in there doing it with you. High pitched sound swelling. Uh, you monitor vitals. Some patients need to be reintubated because 10 to 15% of extubations fail. That's hard when you have to reintubate them again. It's not fun. So, signs of failure: stridor, severe respiratory depression, distress, not depression, distress, dropping oxygen saturation despite high flow oxygen. If this happens, call for help. Don't wait. But most of the time, extubation is beautiful. Patients cry, families cry. You might also cry because you just help someone come back to life. Anyway, what I wish I knew. Before we wrap up, let me tell you what I wish someone told me before my first ICU rotation. Lesson one: trust your guts. If something feels wrong, even if the ventilator alarm is not speaking up, I've seen some of my preceptors, my nurses, catch problem before alarms went off because they noticed the patient looked uncomfortable. The breathing pattern changed. Something just felt off. Don't ignore that feeling. There's a reason why we have that doom is about to come feeling. Don't ignore it. Ask for help early. Lesson number two is ask for help early. You're not supposed to know everything. Respiratory therapists are your best friends. In ICU, there's about two respiratory therapists that are just on the floor, right there. They're just there in case anything should happen and you need them. Call them. They're your best friend. They're like our BFF, best friends for the rest days. Call them, ask questions, learn from them. I have learned a lot from Altis in the past few weeks. Than okay, I have learned a lot from them. Basically, that's what I'm going to say. Because based on previous learning, it just clicks. Like when you now like hear it from another perspective, like oh, that makes sense. Lesson number three: ventilator is a tool, not the patient. Yes, you need to understand the settings, the alarms, the modes, but don't get so focused on the machine that you forget the human behind the machine or the human. Talk to your patient even if they're sedated. In ICU, you always want to let your yes, they're sedated, but you always want them to know what's going on. Remember, even though they're sedated, they can still hear. Even if you think they can't hear you, tell them what you're doing, that they're safe and that they're getting better. That is, if they're getting better, you always want to be honest. You don't ever want to give false hope because some of them can hear you and your voice might be the only comfort, only source of comfort they have. And when they wake up days later and thank you will remember that feeling, that why you became a nurse. So this is the wrap up section because it's been a minute. I thought I was going to spend 30 to 50 minutes, but apparently we're going 1 hour. Let's recap what we need to remember. Okay. One, Mechanical ventilation is positive pressure, opposite of your normal breathing. Normal breathing is negative pressure. It affects more than just the lungs. It affects your cardiac output, it affects your blood pressure, and it affects your kidney. Two, settings matter. FiO2, tidal volume, PEEP, rate. Each one of these has purpose. Understand them. Three, modes determine level of support. AC, most support. CPAP, least support. 4. Alarms are symptoms, not problems. Assess your patient first, then troubleshoot the machine. 5. Complications are real. Watch for VAP, ventilator associated pneumonia, Barotrauma, lung injury, Volutrauma, sorry, too much volume, oxygen toxicity. They they have above 100%. They have 100% oxygen for too long. Oxygen is a medication. 6. Weaning is gradual. You don't just get them from a high to a low. That's crashing. No, you go slow and steady. Criteria, follow criteria for SBT, sedation, breathing trial before you extubate. And remember, when in doubt, you don't really know what to do, you don't know what is going on. Use your army bag the patient manually, and call for RLT, call for help. You're not expected to be an expert, even though you have plenty years of experience. You are expected to keep them alive while the experts arrive. If this video helped you, hit that subscribe button. We are going to dive deep. We're going to go into deep dive into critical care every week. I have my exam next week, so this is me getting. I am also learning because for me to teach you, I have to understand the concept myself. So it's helping. So next time we would talk more about the next critical care. Drop your questions in the comments. What scares you the most about ventilators? I will try my very best to read every single comment and answer them if it needs to be answered. And hey, I know ICU is intimidating. I know ventilators seem overwhelming, but you are going to be amazing because you are here, you are learning, you are preparing, and that is how you start. That is how great nurses do. I'll see you next time. Now, go study and be the nurse your patient needs, and remember, you got this. Peace out.